All right, it's another Thursday, so let's hop right on in. We've only got a few studies this week, so it's going to be a nice and short video. First up, sleep quality and TMD, symptoms among young adults, a cross-sectional study. Let me see if I can actually zoom in on this thing here. Basically, if we go down to what they found in this research, there is a significant association between poor sleep quality and heightened temporomandibular disorder symptom severity in adults. Things such as demographics, age, gender, marital status played a role in the variables and how much each one influenced that condition. Basically, like most other things in the human body or most of the other musculoskeletal conditions in the human body, it's a multifactorial process where we have to take the whole person into consideration, not just focus in on the problem that the patient may be reporting, but as well as taking into account everything going on in their lives to figure out where to best address and take the first steps in managing whatever condition they come into the office with. So if you have TMD, just like if you have low back pain, we are going to be asking about where you are at physically, mentally, socially, and anything else that we feel is going to play a part in exacerbating and or improving your condition. So with this one, obviously sleep evaluation is going to be huge. So if you're not getting a good night's sleep, we're going to try and tackle different ways to improve your night's sleep, in addition to doing any and all of the in-person, in-house therapy procedures that we have at hand, as well as rehab. So I like it because it really just shows off, like everything else, this condition is multifactorial. So if we're moving into another way that we can treat temporomandibular disorders, one is resistance training of the wow, I cannot talk today, masticatory muscles for patients with TMD. So that's going to be the muscles associated with chewing or mastication. So let's go through it. Systematic review to evaluate the effectiveness of resistance training as a treatment for managing pain and improving performance in individuals with TMD. So it followed a protocol, which was registered, yada, yada, yada. Randomized controlled trials or non-randomized controlled trials were included, or sorry, non-randomized studies of interventions were included to compare the effects of resistance training targeting those muscles in regards to pain, performance, and maximum mouth opening in patients with TMD. The results were, it screened almost 2,200 articles and only 3 met the inclusion criteria and involved 108 participants. Kind of amazing when you think about it. A simple question, resistance training, but it is of an area that gets overlooked when it comes to any sort of physical intervention that isn't somebody doing something to you, i.e. resistance training, mobility training, self-management training, etc. There are very few dedicated articles showing improvements, even though clinically a lot of practitioners are doing this. From a research standpoint, there's not that much evidence that's been given grants to pursue these types of answers for us. So we have to rely on clinical results and not just research when it comes to this area. But we do have this article at least. So let's finish up what it says in the results. All the studies included demonstrated a decrease in pain intensity and improvement in the neuromuscular performance following resistance training, even if the superiority of resistance training over other interventions remains uncertain. The combo of moderate risk of bias, heterogeneity, and small sample size results in a very low quality of evidence at this point. Hence why I said we have to rely on clinical results for now, while like some other things that we deal with in the conservative world, the research essentially catches up to what we're doing and what we see. So that's how evidence works. You see something that might work, you put a case study for it, make a case, then it goes up the chain where you can then get grants and money to actually set up parameters and have it isolated to study to see what the effect was, if your hypothesis was correct. And then it keeps going from there until eventually you get enough trials where you can do a randomized control trial and then a systematic review of all of those trials put together to see what a best practices answer for the original case study is. So what was the actual mechanism involved where the case study caught something? Was it a placebo? Was it an external factor that couldn't be easily controlled for? Or was it the original hypothesis that the person doing whatever or seeing whatever it is they saw in practice, is that what they thought? So that's kind of how these things work. So that's the stage we're in when it comes to resistance training. Not that much from a systematic review standpoint. we have to rely on clinical case studies and clinical results for now. And eventually we'll get enough going where we can add more studies into the pool for systematic reviews to pull from to give us a stronger level of evidence for. Now, conclusion. Clinicians managing patients with TMD should consider resistance training as an effective conservative option in conjunction with other treatment modalities. That's exactly what we do here. Future methodologically robust studies with large sample sizes and defined exercise protocols are needed to investigate the role of resistance training for reducing TMD-related pain by increasing load tolerance, et cetera, et cetera, et cetera. So essentially everything I just said. So one of those articles where, I guess all of that, paying money for an education did kind of pay a little bit, did a little something, but I digress. Let's finish this up because, like I said, this is short and I don't want to take half an hour of your time here when we've only got 4 studies. Is stretching exercise superior to steroids for sustained relief and plantar fasciitis? Evidence from a prospective study. So it included 100 patients randomly assigned to 2 treatment groups, one undergoing plantar fascia-specific stretching exercises with anti-inflammatory medications, contrast bath, and shoe insole, and another one receiving a single corticosteroid injection on the medial to heel pad on the most tender points after local sensitivity, followed by anti-inflammatory meds, contrast bath, and shoe insole. So basically the only difference was they both received the same thing. One just received stretching, one received the injection with the other modalities thrown into both groups. While the steroid group showed superior pain relief and functional improvement at the 2 and 6 week mark, the stretching group demonstrated significantly better outcomes at the 12 and 16 week mark, favoring stretching for long-term results, which is something we see for a lot of the other conditions that compare corticosteroids to others. In the short term, if for the right condition, it is hard to beat the steroid. However, you trade in a little bit for, you basically trade in $1 for 2 later, where that steroid is going to stop the process, which means if you don't dedicate some time to taking control of whatever got you in that situation that you needed the corticosteroid to begin with, once it wears off, you're no better or potentially even worse off because now you had that 2 to 6 weeks of relief that you were still not doing whatever it is your body didn't, you didn't change habits that got you there, and your body now is kind of going to dial it up and go, hey, yeah, you never fixed this and now we're just as bad or worse. That's the common story that I hear in my office all the time. So corticosteroids in and of themselves can be a useful tool so long as you understand their place when it comes to your recovery. Too many people want to just think, hey, I got a steroid shot, I'm all good to do exactly what I was doing before without redressing and taking a look at my lifestyle factors, movements, diet, sleep, etc. And I'm just going to rely on the corticosteroid to do everything for me when it is just a very, very powerful anti-inflammatory focal drug that knocks out what you feel from that inflammatory process. It stops it. And if you're just going to step right back into the fire, why get the shot in the first place? I send patients out if they need acute relief and they can't tolerate initial conservative measures for it. Like one comes to mind for a gentleman who had a job where he was lifting overhead, couldn't do it at all, and nothing was going to work with him within the next 72 hours. Like that was just the nature of his diagnosis. And it's just like, look, we could try and just do this quote unquote correctly, which is conservative care, get you back what you're doing, and it's just going to take time. But he was in such an amount of pain that he would have had to have taken off work, used up all of his vacation days and then some, not getting paid for that amount of time. And he was not in a position to be able to do that. So we had the conversation of, all right, let's get you a consult and an appointment date for a corticosteroid shot so that you can remove that initial barrier of pain to get back to work. All the while, you are also then going to be working with me, and we're going to monitor you over an extra couple of months just to make sure that nothing comes back, because now we're rehabbing through a lot less. There's a lot less breaks on his rehab. So some people will get a little bit, how do I phrase this? The Two common pitfalls when it comes to rehab is that you either go too slow for too long or too fast too quickly. And when you have a corticosteroid shot, it is very difficult to dial that in accurately for your patient, because on the one hand, you understand they have a corticosteroid shot and you don't want to move very fast at all because they have no, like, if it works, they have no pain. But at the same time, um, they have no pain. So you may just all of a sudden go gung ho, get them all the way to do 110% of what that joint or muscle could have done in the first place. And then when the shot wears off, they may start feeling worse for wear. So that's why when I talk with my patients, I'm just realistic. It's like, all right, the shot's going to do what the shot's going to do. We're going to do what we normally do during this process, and we're going to rely very, very heavily on more objective metrics. So in my office, we have muscle testers with dynamometers, and we're actually getting a set of force plates so we can assess how the body is actually inputting force into the system. And we're going to rely really heavily on those metrics while you have the shot, and make sure that we're monitoring you past that 6-week mark at the very least, if not into the couple of month mark, just to make sure that our objective tests are progressing in the right direction, and then your symptoms do not return twofold now that the corticosteroid is wearing off. So just food for thought when you're considering corticosteroids. They're the right thing for, they have to be the right thing for the right person at the right time, just like everything else that we've discussed on this channel before. So I think that's the longest I'm going to rant on any single one of these. So let's move on to the last one. And it is, again, therapeutic exercise in patients with derangement of the temporomandibular joint, a prospective study. So instead of a systematic review looking back, this one's kind of asking the question, like I said, 2 studies ago. So let me see if I can jump, because this one's in a different format that's a little bit off here. Uh, where is a good place to jump in here? Here we go. Assessments were conducted before treatment at 4 to 8 weeks post-treatment. Most patients underwent disc displacement with reduction, and nearly half of patients had issues in both TM joints. There was a consistent and significant reduction in pain levels, jaw sound, and jaw movement over the 8-week period for both the right and left sides, according to a patient's self-assessment. The right and left lateral excursions, so how the jaw moved left to right, showed significant improvements after 8 weeks, suggesting that exercises had a positive effect on lateral jaw movement. However, the measurements for maximum mouth opening and protrusion showed no significant changes over that short 8-week time frame. Exercise therapy, therefore, could effectively relieve symptomatic and clinical characteristics in patients with some sort of jaw joint issue. And just like the other studies, it's kind of a, well, yeah, makes sense. I've seen that clinically, and it just comes down to really assessing the person in front of you. What is the issue? Since the jaw joint is unique in the sense that it is a fixed joint with 2 condyles, so let's compare what a lot of people will compare to the next closest joint structure, and that will be your actual pelvis. Your pelvis has 2 ilia or ilium, and they have wings essentially that people think meet in the front via a bone. And it's not a bone that connects the 2 sides of the ilium by the front of your groin and the sacrum in the back. There's actually, like a spinal disc, a very, very solid structure of connective tissue called the pubic symphysis connecting 2 sides. And the fact that it's connective tissue allows for some movement to be sheared or stressed through that area, and allows for counter movements of our pelvis. So it lets our hips, even though it's not a lot of movement per se, it lets our hips move individually from one another from side to side. It gives us a lot of that mobility. Your jaw, your mandible, the bottom part of your jaw that actually moves, the part that's moving as I'm talking to you, does not have that cartilage in the front. It is a solid bone connected from one side of your skull into the TMJ to the other side of your skull into the other TMJ. So it is a solid joint. So this is one of those where it makes sense, if there is a joint issue, because there's a unique disc structure in there, that it could play and have an effect on the entire apparatus as a whole. And it would really come down to assessing an individual in front of you, making sure that their neck doesn't have any symptoms, that you're taking care of not just one side of the jaw that's symptomatic, but the other side of the jaw, since it's a direct connection, that you're addressing the musculature, you're addressing the sleep, nutrition, and that you're incorporating resistance exercise with tolerable levels of manual therapy if it's warranted to make sure that you give the jaw the best shot it's got to recover with a conservative management style. Um, yeah, again, a lot of these studies overlap in what we really were covering, so that's an awesome thing. And it's nice and short. Like I don't have much else to say. I got my rant in when we talked about the corticosteroid, but yeah, a fun, short little video for today. So thanks for sticking along and see you next week.